Well, so innovation has been so amazing in not only vaccines, but also drugs. Perhaps most prominently, getting the triple drug therapy, the antiretrovirals, down in cost and getting those out to millions of people. It's a story of science, it's a story of generosity, but it's a story that still has a lot that we need to do. Here's a chart that's out of the Goalkeepers report. That's the report we put out last week. For those of you who haven't seen it, I highly recommend it. This is the first time we've been able to take a lot of the key issues and not only document where the progress has come, but also look at the future to do some forecasting. And we take assumptions, positive assumptions, and show with kind of a green area what happens if we do things well, and in a red area, what if we take off the pressure and we aren't pushing forward. And you could say the theme of today's event is to make sure that we're, for all the different areas, achieving that green instead of the red. But let's look specifically at HIV. Of course, before 2005, what you see is really quite horrific. This is the number of HIV/AIDS deaths, the rate, and it went up very, very dramatically and peaked in about 2005. 2005 is where the world made the commitment to get these low-cost drugs out to as many people as possible. And something wondrous took place. The number of deaths came down quite dramatically. And so that is super good news. We had funding, we had commitment, we had people thinking about how to get those drugs out there. But looking from this point forward, there really is a risk that that death rate could go back up. Part of that is that we have much larger population size. The number of people in the youth cohort who are most at risk has expanded very dramatically. And so we are challenged to maintain the funding. The red line, actually the line, the one that's the worst there, is where we took and put into this model the United States, which is by far the biggest funder of getting these medicines out, if it went through with the cut that was in a proposed budget. And what that would mean is over 5 million more deaths between now and 2030. And so this field, we've had generous funding. In fact, the greatest single additional funding for any sort of aid or health type issue is what took place through Global Fund and PEPFAR. Now that funding, in the best case, will go up slightly, but not as quickly as the number of people we have living with HIV. And so this idea of how do we treat more people, keep them compliant with the medicine to protect both themselves and make sure they don't spread the disease, that's an area where we need lots of innovation. Now, I've been very lucky to go out into the field and meet people who are trying out different approaches to see where in all the world, but particularly in Africa, where are they achieving this high compliance in a very efficient way. We had a meeting about that topic in Tanzania 3 years ago, and that's where I met Tom Ellman. Our HIV team had seen his work and really thought I should know about it. And that conversation was a very big catalyst for us. Although we're not a direct funder of Doctors Without Borders, we've decided to take a big role in trying to get this approach out to as many places as possible. And I think you'll be very impressed, like I was, at what he's doing in the field. So please welcome Dr. Tom Ellman of Doctors Without Borders.
Thanks. I should start by saying it's not really my work. It's the work of many, many thousands of people working with us and our partners in the field. I'm afraid I haven't got any gadgets or a motorbike, which is a shame. The problem with doctors, and I'm one, is that we think we know it all. I guess some of you have met a doctor. We don't like trusting patients. We've had a long training, they haven't. We're professionals, they're not. And this attitude has informed HIV treatment for decades. Testing could only be done by a specialist counselor. You had to see a specialist doctor in a centralized clinic who was the only one who had the holy grail of these antiretroviral drugs. And you had to return every month to get your drugs. And it worked. We had impressive successes. There are now 19 million people on treatment. Over half of the people who need treatment are on it. But the global target, the global goals target, is to leave no one behind. And right now, we still have more than 20,000 people a week dying of AIDS. Something has to change. I want to talk briefly about our experience in Mozambique in Southeast Africa, where MSF has been working with the Ministry of Health treating HIV since 2003. At first, the model followed the usual pattern, so we had centralized clinics, hugely overloaded with thousands of people. Staff could only spend a couple of minutes with each patient, so they missed the sick ones because they were too busy with just filling out the paperwork. And patients had to travel for hours on foot every month to come to this clinic and pay for the transport. They had to queue. Not surprisingly, up to a third, I would have dropped out, up to a third of them dropped out within a year of treatment. The system was not fit for purpose. Around 2007, a small group of patients from remote villages around Tet decided to break the rules. Rather than walking for hours every month, they formed small groups, and in rotation, one of the group members would go and pick up drugs for the others. It sounds so obvious, but what was special here was that rather than the doctors doing the usual thing, saying, no, you have to follow the system, this is how it works, they listened. And this became the way that they worked in Tet. That was the start of the community antiretroviral treatment groups. Now, since then, this kind of approach has become known as differentiated care, and it's being adapted by many different organizations and governments in different ways and settings. The CAGs are just one of many examples. One size doesn't fit all. And the essence of the models is very simple. You listen to patients, you trust what they say, and you adapt your services to their needs. Bottom up, simplified, demedicalized. Who provides care? Rather than a specialized doctor coming to see you each time, nurses can initiate care, and peers, people like you, can learn to deliver the drugs. They can look after your basic needs, counseling, and provide support. Where's care provided? Closer to home. In Kinshasa, in Congo, we've developed a system of community-based pharmacies run by patient groups. How often do you have to see a nurse or doctor? Well, come if you're sick, but if you're well, why would you come to the clinic? Come once a year. And in between, let's make sure we give the drugs for as long as possible, long refills, and if you have to come, there's a fast-track service, so you can pick up your drugs quickly rather than waiting. And unsurprisingly, the results are much better. We have data from a variety of approaches in different settings across Southern Africa, showing this, that the visit costs are less for both the patient and for the system. There's less time spent by the patient, who doesn't need to spend a long away from their family, and by the staff, who can focus on the patients more in need, people more likely to die. And in the green, the most important thing, this is from Tet actually, that retention after 4 years is much better. Less than 10% of people were lost to follow-up after 4 years in treatment. And perhaps most importantly, these things are being scaled up. Governments are listening, and across Africa and across Mozambique, the CAGs were taken up nationally, and this is from South Africa, where another form, the adherence clubs, have been rolled out across the Western Cape and are becoming the standard of care for all stable patients. Perhaps most importantly, these models can build networks of empowered patients, a social fabric to help break the stigma and for people to support each other in dealing with the barriers they face. I know how this sounds coming from me, a white, male, European doctor. Cacilda Fumo, someone who used to work with us in Mozambique, can describe much better than me. She can't be here, but we have a short video to show of Cacilda.
Eu chamei Cacete da Mica Chumo. Eu sou HIV, eu sou positivo desde 2002. Pensei que havia de morrer. Gostava de ouvir o galo ao cantar o gatinho, eu tinha que despertar, senão havia de passar se eu vivo ou não. Mas pronto, fui ganhando tempo, também descobri que tinha outras pessoas. Então foram meus amigos aí, para nos unirmos a esforço. Ter privilégio a medicamentos, ajudamos a pessoa a ficar forte, sabendo que não estou sozinho. Nos gatos somos família. Eu quando tomo os meus comprimidos, sinto-me a fortificar mais a minha energia para ter mais força e ser mais saudável. Eu quando tomo comprimido, penso que as pessoas não estão a aderir ao tratamento com muita pena, porque estão a perder a oportunidade que ainda têm de viver neste mundo tão lindo. As pessoas quando desistem do tratamento, outros morrem. Se for falar do número de buscas, como se pode, mais ou menos 500, posso apostar nos 500. Ajudamos nos 500. Por amor.
Imagine what could be achieved if we put more power into people like Casilda's hands, the tools that they need, the knowledge and the funding. But there's a problem with this system. It has strings attached. In order to get into it, you already had to be on treatment and stable on treatment. You had to be someone the staff trusted. You were coming regularly. They decided whether you got in or not. In other words, you already had to get past numerous barriers that people face in accessing treatment. If we're to leave no one behind, we need to go much further. We need to adapt these systems to make sure that they work for people who can't pass even the first hurdles of getting tested and getting onto treatment. We need to adapt them for the hundreds of millions left behind in conflict zones, in fragile states, for migrants and refugees, the kind of settings where Médecins Sans Frontières spends most of its time working. In Western Central Africa, people are left behind. 30% of all HIV deaths occur in Western Central Africa. We need to adapt for adolescent girls, who are among the most at risk of HIV. For men, we need to adapt for critical and excluded, criminalized populations, like sex workers, like men who have sex with men, like drug users, transgender populations. Nowhere is peer-led delivery, that someone who, like you, needs to be involved in delivering your care, more important than amongst these groups. Imagine having to rely on a health system that treats you as a criminal. It's impossible to imagine getting care in that kind of system. For prisoners, for the sick and those who've fallen out of treatment, we need to find ways to welcome them back into treatment. Because to reduce mortality, we have to adapt our care to their needs. And we need to adapt the approaches for other diseases. And there are many examples. Tuberculosis, an ancient disease, remains a global emergency and has overtaken HIV, killing 1.8 million people every year. But TB still functions in many countries on the basis of mistrust. You have to be witnessed, direct observation, taking every pill. Surely more could be done to bring the differentiated care and patient empowerment principles to TB. Family planning. Young women and adolescent girls who want contraception must still rely on busy and often judgmental professionals in clinics to get what they need, and their needs are not being met. Whether gender equality, inequality, conservative attitudes, or politics, like the US global gag rule, prevent access to contraception or safe abortion. Wherever these things happen, women and girls are dying. Differentiated care principles can put control back into their hands. The vision, then, is that we develop a system based on trust and a partnership between professionals and communities. We build it based on very simple, easy-to-use diagnostic tools, like self-tests. Anyone can use them. Safe, long-acting drugs and supply systems that take them directly to the hands of the patients, not just to the clinics. And we need research and development systems that will focus on developing tools based on these needs, even where there's no profit to be made from them. Health professionals must be willing to give up some control, to share knowledges and tools with their patients. And we need more funding. HIV funding has fallen in the last 2 years to levels not seen since 2010. If PEPFAR is focused overly on the 13 countries, what's going to be happening to the other countries? Are they going to be left behind? We do need more doctors and nurses and community health workers, hospitals and clinics properly equipped to save lives. We need more better paid frontline health workers, but focusing on patients who really need their help. And finally, we need to invest in peer leadership, in community activism, patient empowerment. And this is a critical role for the international community, because national governments, whether they're in rich countries or poor countries, rarely want to fund those groups that hold them accountable for people left behind. Meeting the global goals will depend on action by these empowered communities. Without their voices, the HIV response might never have started. But with them, leave no one behind can be more than just a slogan. Thanks.